Ma'am, please start, ma'am.
Okay, good evening, everybody. And at the outset, I'm thankful for Shield Pharma for giving me the opportunity to speak on the topic of PCOS. It is very close to my heart. I'm thankful to all my friends and seniors who have joined this webinar. And PCOS, as we all know, is a multifactorial metabolic disorder. It involves many genetics and environmental factors are involved in this PCOS. So nowadays, because of the lifestyle and food habits, the incidence of the PCOS has increased in our country. So PCOS is governed by the genetic and the metabolic factors. It was first discovered by Steen and Leventhal. So initially, it was known as the Steen and Leventhal syndrome. So exact etiology of the PCOS is unknown, and familial inheritance is associated with this. And it has been told that there is a autosomal familial dominance is there. The PCOS is a collection of signs and symptoms with no one single diagnostic test. So the most common pathological characteristics include hyperandrogenemia, insulin resistance with hyperinsulinism, and abnormal gonadotrophin secretion. So we all know female reproductive system, and we all know about the PCOS symptoms. It is associated with irregular period, amenorrhea or oligomenorrhea. Excessive androgen is present, which is causing the acne and hirsutism and other symptoms related to excess androgens. And it is related to polycystic ovaries. These days, everyone is getting ultrasound very often, and by finding the large number of the follicles arranged at periphery, we called it polycystic disease. So only finding the multiple follicles arranged at periphery is not the diagnostic of PCOS. So in PCOS, the ovaries may develop numerous small collection of the follicles and fail to regularly release the egg. Genetics is involved in PCOS, as we have already told. The genes with function is TGF beta pathways, insulin signaling, and the patients with type 2 diabetic mellitus, if they are associated with obesity, there is an increased incidence of the polycystic ovarian syndrome. The recent genetic approach that are gaining popularity in PCOS is genome-wide association studies and the next generation sequencing. Developmental origin of the PCOS, genetic predisposition in PCOS, as we can see the ovary with the multiple follicles. There is a genetic predisposition to secrete excess androgen, which is responsible for PCOS. Maternal environment also play a very important role. What are our food habits, lifestyle, whether we are doing exercise or not. And it has been found that there are certain environmental disruptors like plastic we are using these days, plastic bottles. These cause increased estrogen level in the childhood, which is responsible for polycystic ovarian disease. And because of the activation prenatally in infancy and at puberty, there is an increased testosterone level, and because of the increased testosterone level, there is an increased LH, and it causes an ovulation. Increased testosterone level is responsible for insulin resistance and hyperinsulinemia. Hyperinsulinemia is related to diet. What diet we take, diet plays a very important role. Genetic PCOS is also caused by genetic factors, and it causes the follicle development, and sterogenesis is responsible in PCOS cases. Insulin resistance is caused by genes regulating like insulin secretion, insulin action, and adipose tissue. Etiology of the PCOS is not known. Genetic factors is mainly involved, and it is multifactorial endocrinal disorder. And most agreed that the ovary rather than the adrenal is the principal source of excess androgen production. Excess androgen production by the adrenal gland is called the congenital adrenal hyperplasia. But in case of the PCOS, excess androgen production is due to multiple follicles and thicker production of androgen by the thicker of ovary. Morphology of the polycystic ovaries are the ovary with the 12 or the more follicles measuring 2 to 9 millimeter in diameter or more. There is an increased ovarian volume, more than 10 cubic centimeters. Follicles are usually peripheral in location. There are certain symptom-wise data all over the world. Hirsutism is all over the world is around 23 to 25%, and highest incidence is found in the Philippines. And facial hirsutism is present in whole cohort and all over the world. The highest incidence in United States, it is around 73%. And infertility is very common in case in Philippines, and family PCOS anamnesis is present in all over the world. The bloating is seen in all over the world. There is obesity, and bloating is present because of the fluid retention of the due to the increased level of the androgens. Baldness is there, and highest incidence of the baldness is found in case of in Philippines. And irregular cycle is there. Irregular cycle is also there, and it has been found in all over the world. Irregular cycle is the most important symptoms of PCOS. There is an incidence of the high glucose level, high cholesterol and glucose level, and the hyperpigmentation is very much common in Indian population. There is a history of heavy periods in few cases. As there is a increase, there is a it is increased in those cases because of the unopposed action of the estrogen. So, have incidence of a heavy period is also very common all over the world. Acne is found in its very common symptoms in case of the PCOS. So, it has been, this slide is showing the PCOS diagnosed, and a certain percentage of the PCOS is not diagnosed. Hypothalamic pituitary ovarian axis play a very important role in ovarian function, and in case of the fertility, it has a very important role. It is responsible for the reproductive competence and the survival of the species. In case of the PCOS, hypothalamic pituitary ovarian axis is disrupted, and the polycystic ovarian syndrome is a disorder primarily characterized by signs and symptoms of androgen axis and ovulatory dysfunction. It disrupts the hypothalamic pituitary ovarian axis. Pathophysiology of the PCOS, although is still not entirely clear, is there is a hormonal balance caused by both hyperandrogenemia and the hyperinsulinemia, which are also effects of PCOS. What are the current concepts of the pathophysiology of the PCOS? There is an androgen axis. Because of the androgen axis is because of the increased GnRH pulses, and because of that there is an increased LH and FSH ratio, which is responsible for androgen axis also. And there is an anovulation and subfertility. It is because of the impaired oocyte development. And ovaries are polycystic as there is arrest in the interfollicle development, and there is increased leptin and adiponectin ratio. Insulin resistance and the metabolic complication is there because of the genetics, because of the obesity, and because of the sedentary lifestyle. How to diagnose PCOS? Symptoms plays a very important role. Whenever a girl or a woman enters our clinic, we can find out she's a case of the PCOS. We can see the acne, we can see the hirsutism, she's obese, there is a history of the infertility, and there is a history of the amenorrhea and the oligoamenorrhea in these cases. And secondly, we can do the ultrasound and we can find the polycystic ovaries. There is a multiple follicle arranged at periphery around more than 12 follicles of 2 to 9 millimeter size arranged at the periphery. So we can confirm the diagnosis of polycystic ovarian syndrome. If the ultrasound is negative, symptoms is there, but ultrasound is negative, we have to go for the biochemical parameters. There is an elevated serum testosterone, elevated free androgen index, and elevated LH concentration, and the fasting glucose and the insulin level is less than 4.5. It is called the insulin resistance. So there is a hormonal irregularities causing PCOS. Abnormal gonadotropin releasing hormone regulation is there. There is an increased luteinizing hormone and decreased FSH level, and there is a decreased response of ovarian follicle to FSH. So the follicle, there is a no recruitment of the follicle. Multiple follicles are present, but there is a difficulty in recruitment of the follicle, and there is a little response to the FSH. There is an increased anti-Mullerian hormone, and there is a follicular arrest. There is an increased secretion of the testosterone, estradiol, and the dihydroepiandrosterone level. There is involvement of the neuropeptide in the polycystic ovarian syndrome. Kisspeptin is a neuropeptide that upregulates gonadotropin releasing hormone secretion. It is an essential element for the luteinizing hormone surge and ovulation. Women with polycystic ovarian syndrome expose alteration in the both GnRH and the LH secretion levels. In PCOS women, LH commonly increases. FSH is typically in a lower range. This may be related to the decrease the sensitivity of the GnRH pulse generator to steroid feedback and enhance the LH secretion. The elevated level of the GnRH and the LH in PCOS women may be related to the cumulative effect of altered GnRH simultaneously and inhibitory neurotransmitters in the hypothalamic pituitary center. So the detailed mechanism for how the kisspeptin is involved in the pathogenesis of PCOS is still unknown, but kisspeptin is a neuropeptide which plays an important role for GnRH and the LH secretion. Insulin resistance is commonly found in PCOS patients, with prevalence being estimated in 50 to 70% of the cases. PCOS is associated with peripheral insulin resistance and the hyperinsulinemia, and obesity amplifies the degrees of the both abnormalities. Insulin resistance in PCOS has been associated with adiponectin, a hormone secreted by the adipocytes that regulates the lipid metabolism and glucose levels. It has been found that the adiponectin is present in the adipocyte cells, and it is not necessary that all the patients with the obesity has a large amount of adiponectin. It has been found even the lean PCOS, if there is a large amount of adiponectin, there is increased chances of PCOS in those girls. Both lean and the obese women with PCOS have lower adiponectin levels than the women without PCOS. So PCOS has adiponectin has a very important role for metabolism of the of glucose levels. Insulin resistance causes the hyperinsulinemia, and it is related to, it causes the decreased sex hormone binding globulin production by the liver. And there is an increased ovarian production of androgen and disordered release of the LH and FSH, increased ovarian production of the androgen causes the hyperandrogenemia and all the symptoms of the acne, hirsutism, etc. And hyperandrogenemia causes the oligoanovulation or absent or irregular ovulation. And all these are the symptoms of the PCOS. It was first observed that the patient with PCOS were hyperinsulinemia in response to an oral glucose tolerance test. It is now known that the insulin resistance and the development of the compensatory hyperinsulinemia is a frequent finding in PCOS. The insulin resistance of PCOS patients that underlies many of the features of this disorder is highlighted by the finding that the administration of the insulin sensitizing agents principally metformin, thiazolidines, and the myoinositol and dechiroinositol, has been found to improve these features in many patients. Women with PCOS have intrinsic insulin resistance independent of the extent of the obesity and magnitude of the androgen concentration, as we have already discussed. Even lean women with PCOS manifest insulin resistance. Increasing body mass index exacerbates insulin resistance. But it has been found if their body mass index is increased, there is an increase in the insulin resistance. It has been found that a decrease in 5% weight of uh, total weight uh, decreases the insulin resistance to a large extent. Normal weight adolescent girls with PCOS have peripheral insulin resistance, increased liver fat, and muscle mitochondrial dysfunction compared with the normal weight girls.
PCOS is associated with peripheral insulin resistance and hyperinsulinemia, and obesity amplifies the degree of the both abnormalities, insulin resistance as well as hyperinsulinemia. Adiponectin and PCOS, as we have already discussed, there is level of the adiponectin is decreased in case of the PCOS. Insulin resistance in PCOS has been associated with adiponectin, a hormone secreted by adipocytes that regulates the lipid metabolism and the glucose levels. Both lean and obese women with PCOS have lower adiponectin levels than women without PCOS. The compensatory hyperinsulinemia associated with insulin resistance provokes excessive ovarian or adrenal androgen secretion and decreases hepatic sex hormone binding globulin synthesis, with the net result of the increasing circulating testosterone concentrations. This leads to the paradox of the insulin signaling in PCOS, liver, skeletal muscles, and adipose tissue, which exhibit insulin resistance, whereas steroid producing tissue and the pituitary retain insulin sensitivity. This paradox is illustrated by the differences in the insulin actions in granulosa lutein cells obtained from women with anovulation with PCOS. Insulin stimulated glucose uptake is impaired, whereas insulin stimulated progesterone production is preserved in case of the insulin resistance cases. It has been known that the numerous genetic and the epigenetic factors, non heritable prenatal and the extrauterine environmental factor, and environmental disruptors influences and varying adaptation to the nutrient axis likely contribute to the development of the insulin resistance and the hyperinsulinemia. The prevalence of the metabolic syndrome, defined as obesity, hypertension, dyslipidemia, and hyperglycemia, is approximately threefold higher in women with PCOS. There is an increased chances of the metabolic disorder in those patients with PCOS. Altered FSH and LH ratio further enhances hypersecretion of androgens in the theca cells in the ovarian follicles. The increase in the follicular androgens impairs follicular development and reduces the normal inhibition of the gonadotropin releasing hormone. uh, Gonadotropin releasing hormone pulse frequency by progesterone, further promoting the development of the PCOS phenotypes. In addition, there is evidence of the resistance to the effect of the FSH at the follicular level in the ovaries of PCOS women, possibly due to the excess local the anti-Mullerian hormone production. It has been found with those women who have a high MH level, they do not respond to the low dose of the FSH, and they are called the FSH resistance PCOS. In those particular cases, the induction of the ovulation occur with the high doses of the PCOS and or either by HMG or with the high doses of FSH. So we have to recognize those cases. We do not respond to low doses of FSH. Most of the time, it has been found they have a high AMH level. In PCOS, the selection of the dominant follicle is abnormal, a consequence of the insufficient FSH stimulation and the local inhibition of the FSH action, possibly due to the excess local androgen and the other intra-ovarian factors that modulate follicular recruitment and the growth. As we have already discussed, there is a there is FSH resistance PCOS. In those cases, we need to have a high doses of the FSH. We have to use the step down protocol in those patients, or we have to use human menopausal gonadotrophins. Pathophysiological role of the hyperandrogenism and the insulin resistance, hyperinsulinemic state in determining the PCOS phenotypes. In hyperandrogenism, is responsible for signs and symptoms of the androgen axis, including anovulation, reduced sex hormone binding globulin, as we have already discussed, abdominal fatness, insulin insensitivity, and the lipid abnormalities. On the other hand, hyperinsulinemia and the insulin resistance is responsible for the metabolic syndrome, which we have already discussed: hypertension, type 2 diabetic mellitus, uh, dyslipidemia, abdominal fatness, and cofactor favoring androgen excess, reduced sex hormone binding globulin, and anovulation. The persistent hyperandrogenism is associated with impaired hypothalamic pituitary feedbacks. So there is a disruption of the hypothalamic pituitary ovarian axis. There is a LH hypersecretion, and the hyperandrogenism causes the premature granulosa cell luteinization, and there is the aberrant oocyte maturation and the premature arrest of the activated primary follicles. There are 10 signs and symptoms of the polycystic ovarian syndrome as we encountered in our day-to-day practice: irregular periods or absent periods, amenorrhea or oligomenorrhea, excessive facial and the body hair thinning and the loss, baldness is there, abnormal skin discoloration, as we see in the albicans nigricans case, acne is there, high blood pressure, weight gain, depression, stress. There is a self-esteem in case of the PCOS patients. Clinical hyperandrogenism is associated with hirsutism, acne, seborrhea, male pattern balding, increased muscle mass, deepening of the voice, and the clytomegaly. So, hirsutism and PCOS. In 15 to 20% of the PCS, they are associated with hirsutism. Most women with hirsutism of gradual onset, with or without menstrual cycle irregularity, have polycystic ovaries. More serious pathology is usually obvious on clinical history and examination alone, and tend to be associated with high elevation of the circulating testosterone. Lab evaluation to consider for PCOS, investigation to consider for hirsutism in women. Most of the time, it has been found in hirsutism cases, the free and total testosterone is increased. In case of the PCOS, the hormone is around 150 nanogram. If it is above 200 nanogram, it is associated, most of the time it is associated with the ovarian tumor or the uh, adrenal tumors. Gonadotrophin luteinizing hormone concentration is greater than follicular stimulating hormone in PCOS cases, but they are not very consistent. The prolactin is sometimes raised in patients with prolactiminomas and those patients taking certain medications. 17 hydroxyprogesterone is raised in congenital adrenal hyperplasia. Dehydroepiandrosteronidiol acetate is raised in adrenal tumors, and thyroid function test has to be done in case of the PCOS patients. Acne is also found in 15 to 25% of cases of PCOS. The majority of the women with severe or the resistant acne have PCOS. Androgen excess has also been associated with more severe acne. So it is acanthosis nigricans. It is a velvety mucocutaneous eruption characterized by the hyperkeratosis, papillomatosis, and increased pigmentation. Occurs in 5% of the women and occurs in axilla, nape of the neck, under the breast, and the flexures. It is most probably definite sign of insulin resistance. The variety associated with PCOS is benign acanthosis nigricans. And by decreasing the weight by 5%, it decreases the acanthosis nigricans also. Of obese women with PCOS, 10% have undiagnosed diabetes and 35% have impaired uh, glucose tolerance. Almost 70% of the patients with PCOS have an abnormal lipid profile and the high triglycerides and low high density lipoprotein. Cholesterol are often found. Uh, as we have already discussed, genetics plays a very important role in PCOS, and lifestyle is very important. Lifestyle modification by exercise, diet, and calorie deficit, we can control many cases of the, mm, we can manage PCOS. So whenever PCOS patients or the women, girl or women come they visit our clinic, we tell them it is not a disease which can be corrected by the medicine. It is a metabolic disorder, and only
हाँ,
the lifestyle modification can
तो दो कपड़े जो उसमें पड़े हैं ना,
hormonal changes, the obesity exacerbations, hormonal changes are there, and there is increased androgens and there is increased insulin level. So, because of the increased androgen and increased insulin levels, ovarian follicles, there is a anovulation and there is a increase in and estrogen is there. Because of the increased estrogens, ovarian follicle anovulation do occur. So, because of the increased androgens, there is the hirsutism and acne, and anovulation can cause menstrual disturbance, and increased insulin level causes the diabetic metabolic syndrome, and cardiovascular risk is always there. Psychosocial issues are always present in PCOS because most of the time they are associated with acne and hirsutism, and they are most of the time they are obese. So they have the clothes do not fit them. So whenever they go to they go to markets to purchase the clothes, they do not fit them. So they have a bad body image. They have a bad decreased self-esteem and depression and anxiety. So we have to deal these girls with the tender loving love, and we have to take care. We have to take care of their self-esteem. We have to uh, talk to them with great compassion. Now we come to the PCOS treatment. Key points is the non-pharmacological treatment and pharmacological treatment. Non-pharmacological treatment include the lifestyle modification. Lifestyle foremost and the most important is the diet. Diet plays a very important role. We have to tell our patient, PCOS patient, that we have to follow the food pyramid. We have to avoid spicy, oily, and all the junk food we have to avoid. And diet including, we have to have the low glycemic index diet. And it is very important to see a dietitian who is knowledgeable in the field of the PCOS. Exercise plays a very important role. We have to burn the calories, and it is advisable that we have to do the exercise 150 minutes per hour. And if the BMI is more than 25, then we have to do strenuous exercise. And weight reduction is very important if the patient is obese or insulin resistant. And it has been found by reducing weight by 5%, all the ovulatory function improves. All acne, hirsutism, ovulatory function, and the regularity of the period, all these symptoms improve by decreasing the weight. But it is better said than done. It is not easy. We have to develop a group of the obese uh, females together. We have to develop a encouragement. We have to have a strong willpower to decrease the weight. Only then we can treat the PCOS. And other factors is pharmacological treatment. Pharmacological treatment include the oral contraceptive pills, anti-androgens drugs, usually spironolactone, and in case of the hirsutism, finasteride is used. And insulin sensitizer is very often used whenever there is a increased insulin sensitivity. Statins are used when there is a high cholesterol levels. Insulin resistance can be reduced, and by reduction of the insulin resistance improves the ovulation moderately and hyperandrogenemia slightly. First line treatment, as we have already discussed, diet and exercise. Diet and exercise played a very important role. All mothers of adolescent girls have to understand that diet and exercise play a very important role. For patients with impaired glucose tolerance, metformin is given, and these days we are giving inositol, myoinositol, dechiroinositol. For metabolic disorder, myoinositol is safe and effective method. In all adolescent girls, myoinositol is a safe and effective method for controlling hyperinsulinemia. Combination of the myoinositol and OCPs is a very important treatment. It causes the anti-androgen effect are enhanced, negative impact of OCPs on weight gain is balanced, and the metabolic profile is improved by adding myoinositol in OCPs. As we have already discussed, and it has been studied many times, that polycystic ovarian syndrome associated with morbid obesity may resolve after weight loss induced by bariatric surgery. So, gastric bypass is the right method for bariatric surgery. And in a study of the morbidly obese PCOS women, weight loss was paralleled by a decrease in the Hirsutism score, testosterone, and the dihydroepiandron sulfate. Amelioration of the insulin resistance occurred, and the ovulatory cycle were also restored. In a morbidly obese patient, when the BMR is more than 35, we need to have a bariatric surgery. Sometimes bariatric surgery is indicated. It has been found that the insulin resistance secretion and the metabolic in users of the oral contraceptives has a very important role. The one of the most used medication in PCOS are oral contraceptive pills. In addition to their androgen lowering effects, it is likely that they protect the endometrium against hyperplasia and cancer. May also reduce the incidence of the functional follicular ovarian cyst. Insulin resistance, as shown in the general population, it has been found that in case of the PCOS, they have a prolonged cycle. There is unopposed effect of the estrogen. Because of that, there is a hyperplasia. Because of the hyperplasia, there is an increased chances of the ovarian cancer. So, oral contraceptive pills regulate the cycle. Because of the progesterone present, there is a regular cycle, and there is a thinning of the endometrium. So it helps to reduce the incidence of the cancer in high risk patient. Uh, it has been found, and it was the original article, that changes in the glucose tolerance with metformin treatment in polycystic ovarian syndrome. A retrospective analysis was done, and while the long-term benefits have not been extensively documented, use of the insulin lowering and the sensitizing medications such as the metformin would be advisable, although they are unapproved for such use in USA. So metformin is not very regularly used in USA. In recent and controlled retrospective observational studies showing that the long-term treatment with metformin delays or prevents the development of the impaired glucose tolerance and diabetes in women with PCOS, and is thus certainly in keeping with this concept. There is a concept that while adding in ovulogens, we for induction of the ovulation, we will be discussing later on. For induction of the ovulation, we use letrozole and clomiphene citrate. By adding metformin, we can improve the ovulation. But metformin alone is not able to induce ovulation. But by improving the insulin resistance, it does help. So certain studies has been done. It has been They have studied the efficacy of the metformin in obese and non-obese women with polycystic ovarian syndrome. A randomized, double-blinded, and placebo-controlled crossover trials were done. Studies showed that the decreased weight and systolic blood pressure as well as the increased HDL in metformin-treated women with PCOS. In this study, metformin was also shown to increase insulin sensitivity and lower testosterone in obese but not non-obese PCOS women. So minostrol is another insulin sensitizer drug. It is one of the isometric structure of the inositol which occurs in the body, and there is a deficiency of the minostrol in PCOS cases. Uh, Minostrol is a secondary messenger for insulin. It's transferring the insulin signal to ovary, secondary messenger in follicular growth, the transferring of the pituitary hormone signal. So in that way, it improves the ovulatory functions. The minostrol helps in normalizing the LH and FSH ratio, thereby reduces the androgens level. It causes the production by theca cells of the maintains hormonal balance. Myoinositol helps in follicular development by acting as secondary messengers. Myoinositol helps in oocyte maturation and the quality by calcium iron oscillation. So, our treatment aim with myoinositol is restore cycle fast, reduces androgen levels, overcome insulin resistance, and improve oocyte maturation and the oocyte quality. And the myoinositol is well tolerated as compared to the metformin. So, minostrol and dechiroinositol combination in the treatment of the PCOS. For obese PCOS, patient with increased BMI more than 25, insulin resistance is very high. Dichiroinositol is excreted 6 times more through urine. Epimerase is the enzyme converts myoinositol into dechiroinositol. So, epimerase enzyme actively is very high with hyperinsulinemia as ovarian level myoinositol and dichiroinositol is given in the ratio of the 40 is to 1. It has been found there is a deficiency of the mychiroinositol in cases of the PCOS. By adding mychiroinositol, uh, all the activity it causes improves the ovulatory function. Insulin is not utilized, leading to hyperinsulinemia. So ovary has a high dichiroinositol level and the low myoinositol level. So ovarian function disturbed due to low myoinositol level. Myoinositol level alone is not enough in obese PCOS patient. So mychiroinositol and dichiroinositol, myoinositol and dichiroinositol in the ratio of the 40 is to 1 benefits in obese PCOS patient. It restores menstrual cycle. It improves hormonal and the metabolic profile, improves oocyte maturation and the quality. It improves embryo to grade 1 and increases sex hormone binding globulins, and it reduces androgen levels and reduces very high insulin resistance very fast. So there is a clinical evidence and many studies have been done. It has been found that the minoxidil effects in women with PCOS. A meta-analysis of the randomized controlled trials were done. Inositol and many studies have been done. The inositol and polycystic ovarian syndrome and metabolic and hormonal effect of minoxidil in women with ovarian syndrome. Double-blind studies has been done, and they have a very positive role in case of PCOS with hyperinsulinemia. So we come to the take-home message. Polycystic ovarian syndrome is the most common cause of anovulatory infertility, one of the commonest endocrinopathies to affect women, represents a spectrum of disease with variable presentations. It is important to diagnose polycystic ovarian syndrome because of the potential long-term consequences. Early diagnosis may delay or possibly prevent some of the sequelae associated with PCOS. Further research is necessary in this syndrome. So, polycystic ovarian disease is the etiology is not known. So, many factors are involved, and it is not a disease. It is a syndrome. It is not the disease that we can treat with one drug. If we start giving oral contraceptive pill, we cannot give for a longer time. We can give for 1 year, 2 year. Ultimately, lifestyle modification, as we have already discussed, diet, calorie deficit, exercise, play a very, very important role. This is a message to all the mothers of the adolescent girls, all the women with infertility and acne and hirsutism. It is very important to understand polycystic ovarian disease. And most of the time, it is advisable. All the doctors having PCOS clinic, most of the time they have a cycle, they have some exercise, sort of exercise in their clinic. So while waiting in the clinic for their turn to come, they do exercise. In that way, the serotonin levels increases and their self-esteem improves. So exercise play a very important role in PCOS. So we have to understand PCOS very well. So thank you very much for patient hearing.
Thank you, ma'am. That was a very informative session which we had. Ma'am, we have two questions our delegates have asked. Shall I ask them, ma'am?
Yes.
One question is, few people are having hyperandrogenism symptoms, but they doesn't have any ultrasound symptoms.
Absolutely
So shall
fine.
we consider them as PCOS? And
It's a very good question. Most of the time, what happens, the question is she is having signs of hyperandrogenism and she doesn't have signs of polycystic ovary in ultrasound. This is very common. As we know through the Rotterdam criteria, two of the three uh, criteria has to be there. As we know, menstrual irregularity, anovulation, or oligomenorrhea, either polycystic ovarian syndrome or hyperandrogenemia. If two of the symptoms is present, it is called the polycystic ovarian syndrome. If hyperandrogenemia is there and anovulation is there, but polycystic ovary is not present in ultrasound, we have to label it to polycystic ovarian syndrome. It is very common that we have seen that on ultrasound we find ovaries is enlarged and polycystic ovaries, but hyperandrogenemia is not present and menstrual cycle is very much regular. So we cannot label it by seeing only ultrasound. We cannot label it as polycystic ovarian syndrome. So sometimes the polycystic ovarian syndrome is overdiagnosed.
ma'am, another question, which is regarding lifestyle modifications. Like in many advices, many guidelines, and they mention that weight reduction, exercise is important. But in few patients, they have even observed that rigorous exercises exacerbates PCOS symptoms. So, how should we uh, help the patients regarding this?
This is a very good question. Most of the time, what happens that they start doing, as I have already mentioned, strong willpower, motivation is very important. They start doing exercise, and when they do exercise, when they do not lose weight, they become hopeless, and they again switch over to the unhealthy diet. Because of that, there is a increased weight gain, and there is a increased signs and symptoms of the PCOS. So we have to be persistent. Sometimes it takes 1 year, sometimes it takes more than that to reduce the weight. We have to motivate. Whenever there is a reduction in the 500 or 1 kg weight, we have to encourage the adolescent girls. We have to encourage them. It is very important. The strenuous exercise definitely will not increase the PCOS symptoms. So unless until there is an increase in the androgens levels are there, there are other causes of hyperandrogenemia, as we have discussed. It could be because of the androgen tumors. It could be because of the congenital hyperandrogenemia. But in those cases, there is excessive hair growth, and there is a very fast increase in the hair growth and signs and symptoms of the hyperandrogenemia.
Ma'am, we had few questions, only two questions which were asked. So the answers are answers were really informative, ma'am. So we don't have a few more questions now. Shall we close the session?
Yeah, thank you very much for giving me the opportunity. Thank you all the friends to be with us.
Thank you so much, ma'am.
Thank you so much, ma'am. It's really a wonderful session, I would say. And even in comment section also, delegates were telling one of the interesting topic with a lot
Very
of
difficult
dilemmas.
and interesting topic.
Yeah,
And
they
most of
said
the time we do not understand why it happens and why all these treatments are given and why the
Exactly.
role of the exercise and diet is there.
Yeah, there is one doctor.
Whenever there is a increased obesity, whenever there is a increased fat, there is a increased this thing fat in visceral organs on the in the ovaries, in the uh, intestine, and all these causes the there is a decrease in the adipoliectin hormones. Because of the decrease in the adipoliectin hormone, the signs and symptoms of the PCOS increases. Thank you very much for giving me
Yeah.
the opportunity.
Thank you, ma'am. Thank you so much. Pleasure is ours. Yeah, thank you. So I'm just closing the session, ma'am, with your permission.
Okay. Thank you. Thank you.
Yeah.
Thank you. Good.